So by bringing those two worlds together, the data from the health system, but also patient voices, we started to get a completely different picture than where the clinicians thought we were at. Hi, my name is Alyce Adams. I'm a professor here at Stanford in the Departments of Health Policy, Epi and Population Health, as well as by courtesy in pediatrics. The one thing I would say that I would want people to take from our work is that we believe that in order to ask the right questions, in order to design studies that have the most potential for impact and for sustainability over time, it's critical that we engage the people affected by the research as collaborators in the research from the very beginning, from setting the specific research question all the way through to dissemination and hopefully translation of that work back into practice and policy change. What's been fantastic about IAJS is that they bring together this multidisciplinary perspectives for how we address real-world problems using research. Because sometimes we've used interventions, for example, that were developed in education or methodologies developed in engineering because they fit the problem, right? So we're not so much, I have a toolkit and I'm going to apply this toolkit to everything, but rather I have a problem that I'm interested in and what tools will work for that problem and then collaborating across silos to address it. Really, the origins of my work go back to my childhood. I had relatives who suffered from chronic conditions like diabetes and cancer, and I saw them really struggling and suffering despite the fact that they had health insurance. And they took care of each other as well as they could, and of course they had health care, but yet they still had these horrible outcomes. And when I asked my friends and my family about why this was happening to them, they said, well, it's just what happens when we get diabetes. And I knew when they said us that they meant Black people. So that really set me on a journey from very early on to try to understand why this happens. We really focus on strategies for addressing disparities, particularly in chronic disease outcomes like diabetes and cancer, within and outside of health systems in a couple of different ways. One is that we work to understand why these disparities persist, particularly among people with health insurance. And then we also try to inform policy and practice so that we get better outcomes at the other side. And so the first place that I started in my early work was really focusing in on how can we make these health systems, these specifically health insurers, more responsive to the needs of patients, and particularly the needs of patients of color and those who are less served by the institution. And that led to our work that really focused on modifiable determinants within health systems of these disparities. Things like differences in adherence to medication, differences in prescribing of medication, differences in treatment changes when patients weren't being responsive, differences in how people communicate with their physicians. If we can shore up these areas, maybe the policies plus the system changes can get us closer to where we want to be. In the case of diabetic polyneuropathy, which is the work that we're focused on, we knew going in that there was this increase, we're starting this increase worldwide in neuropathy. When I talked with physicians, they said, oh, Alyce, don't worry about that. We're focusing on blood sugar, it's fine. And I said, I suspect it's not fine, but we're gonna keep asking questions anyway. So we did two things. We looked at the data to see what was going on in terms of our own patients, in terms of neuropathy. And then we also started talking to patients. The reason for doing both was there's what the health system records, and then there's what the patient does on a daily basis outside of the purview of the health system. So by bringing those two worlds together, the data from the health system, but also patient voices, we started to get a completely different picture than where the clinicians thought we were at. The reason we started down this path was that one of the groups or one of the sort of broader subgroups that's disproportionately affected by neuropathy are indigenous populations. I've done a lot of work in the past with Native American tribes as well as First Nations in Canada on various aspects of this and related issues. But I'd never really worked with the Native Hawaiian community, but I know that's something they're passionate about. So one of my colleagues Connie Trinasti, happens to be leading efforts to use research to inform clinical care at the Queen's Health System, along with her boss, Dr. Todd Cito. And they're particularly interested in diabetic polyneuropathy as well as peripheral artery disease in the heart disease space. When they come together, it's particularly bad for patients in terms of loss of functioning, et cetera. What's interesting about their health system is that it was developed specifically for the health of Native Hawaiians, because at that time, when it was developed, they were not getting good care from westernized systems. So the idea was to create their own health system specifically for Native Hawaiians. So we've been working to help them understand the types of work that we've been doing with other systems, to listen to them about their priorities, what they're concerned about, and where they think we might be able to be useful, and then to collaborate on a number of different proposals to see if we can get started on testing some different strategies. Following the guidelines and paying attention to the literature is critically important. It's a necessary step, it's not sufficient. To really sort of make impact, we need to understand what that looks like in the real world. So it's one thing to say, oh, you should really, do something about your blood sugar. It's something else to realize that people don't have access to fresh fruit and vegetables, that there are aspects of their neighborhood where they don't feel safe exercising or even pay for some of these weight loss drugs that are out now, right? So there's so many different things that influence all of that. And then there's also, particularly for communities that have been historically marginalized, there are also these really big challenges with trusting the healthcare system and what they tell you. And one of the ways we can deal with that is by inviting them into the room, creating community advisory boards, creating patient and family advisory committees, things like that that can help to integrate patient voice and community voice into sort of the infrastructure of the healthcare system, so that the healthcare system starts thinking differently. That was one of the best, I think, accomplishments of our work in the past, was when clinicians looked over, saw what we were saying, we played some of these interviews for them with their patients, talking about what's going on, and you could just see the light bulbs go on. They had no idea. These are good people. These are good people who want to do good things, but they were making a lot of assumptions. And what the patients were telling us was, your assumptions are incorrect, and if you work with us, maybe we can get there together. A just healthcare system is one where everyone has equal opportunity to good health, right? Whatever that looks like for them. It acknowledges differences, but then also expects the health system to be able to address those differences. It's going to require changes in policy and practice, as well as collaboration with community partners. Only through those partnerships can we expect to have those equitable health outcomes that we hope for.